Hi, everyone. We're going to give folks a few more minutes before we get started. But if you'd like to go ahead and introduce yourselves in the chat, we welcome you to do that. Let's go ahead and get started then. Hi, everyone. Good morning, good afternoon, and good evening. Thank you all so much for joining us today for the fourth session of Momentum's webinar series, Strengthening Analysis and Use of Routine Health Facility Data for Maternal, Newborn, Child, and Adolescent Health. We're really excited to have you joining us today, and we welcome you to introduce yourselves in the chat. My name is Emily Stammer. I'm a Senior Research Monitoring and Evaluation Advisor with the Momentum Knowledge Accelerator Project, and I'm really happy to be here with you all today. Before we dig into today's subject matter on data interpretation and use, I want to go over a few housekeeping items in order to provide everybody with the best experience possible on today's webinar. So first, please note that today's webinar and all of the other sessions during this series will be recorded and posted to the Momentum website. So if you're not able to attend any of the sessions or some of the sessions in the series, you will be able to access the recordings and materials shortly after each session takes place. For today, all presentations today are in English. So if you stay in this main channel, you will hear the presenters speaking in English. If you'd like to hear the session in French, please click on the interpretation icon and select the French channel. On a related note, the slides that will be presented today on the screen will appear in English. My colleague Zach will share links in the chat to the English only and French only versions of the slides, so you can follow along with the presentation if you'd like. We will aim to give verbal cues to note when to progress to the next slide for those following in French. Lastly, there will be a single break for questions and answers during today's session after all the presentations are complete. Please click on the Q&A icon at the bottom of the screen to submit any questions you might have as we go along. We'll do our best to respond to questions either directly in the Q&A at the end or in the Q&A box as we go along. So with that housekeeping out of the way, I think we're ready to begin. Next slide, thanks. So a quick overview of the series. The purpose of this series is to introduce you to resources and tools that you can use to strengthen the analysis and use of routine health facility data for maternal, newborn, child, and adolescent programs in your work with country stakeholders. So routine health facility data are an important source of information for decision makers to understand service utilization and service quality so they can identify problems and make evidence-based decisions on policies and resource allocations. In an effort to strengthen the analysis and use of health facility data for MNCAH programs, the World Health Organization, or WHO, developed a guidance document and an accompanying resource package to be used for capacity strengthening in workshop and webinar settings such as this one. So the guidance document describes a catalog of indicators for MNCAH that can be monitored through routine health information systems data. It also provides guidance on analyses and visualizations for the indicators, and it includes considerations for program managers for interpreting and using the data for decision making. The Momentum Knowledge Accelerator project has adapted those materials for this Training of Trainers webinar series. During this series, we'll dive into the different components of the WHO toolkit to show you how to access and use the resources. My colleague Zach will share a link in the chat where you can access the guidance document and the accompanying resources. There's also a link in the slides that you can use to access the web page. So during this webinar series, you'll hear about practical examples from Momentum projects to help illustrate how the concepts covered during this series can be put into practice. And we'll highlight existing resources, including tools and templates that may help support your work. So while some of our colleagues from the Momentum Awards were involved in reviewing some of the materials presented today, and we can answer questions about the subject matter itself, we personally are probably not best placed to answer questions about why certain content was included or excluded from the toolkit. And for those questions or others, I really invite you to reach out to the WHO using an email address that Zach will put into the chat. We've found that they are very responsive. Next slide. So during today's webinar, we'll be looking at components of the 5th and the 7th presentation modules, which cover data interpretation and use. Presentation 6 discusses data viz, and we're saving that piece for our final bonus session that will take place on September 26th. Next slide. And just a reminder that each session in this webinar series has a similar structure and includes the same core components. So we begin by introducing participants to key concepts related to the session's topics and highlight different tools and resources that are available to support your work in these areas. We focus largely on the WHO toolkit, but as I said, we'll also highlight other key resources at the end of the first presentation. We'll then hear presentations from staff from different Momentum Awards and other external groups on how they have put these key concepts into action in their work and suggestions or lessons learned that they can share with you. And then we'll leave time for questions and a little bit of discussion. So today's session, as I noted, focuses on data interpretation and use. And just a reminder for those that may have missed the first 3 sessions, they covered an introduction to health facility data, data quality considerations, and data triangulation and analysis. And these presentations and recordings in both English and French can be accessed on the website dedicated to this webinar series that is on the Momentum website. Next slide. So we have a lot of exciting presentations today that I'm really looking forward to. We'll start with the least exciting pieces. That's the background that I'm going to present, followed by a presentation from our colleagues Scott Merritt and MNCAH Ifemenam from Momentum Country and Global Leadership, and Tapson Nyondo from Zambia on interpreting and using GIS and routine MNCAH data for action, with case studies from both Nigeria and Zambia. Following that presentation, we'll hear from Mary Drake, who is a Senior Monitoring, Evaluation, Research, and Learning Advisor with Momentum Country and Global Leadership, about their work on data for action in Indonesia and Zambia. Next slide. So, digging into today, the objectives of today's session are to provide an overview of the importance of data interpretation and use to support our partners working with routine MNCAH data, to present and discuss real-world examples of how our Momentum and other colleagues have approached this work, and then to highlight key tools and resources that may be useful to you when supporting partners doing this kind of work. Next slide. Great. So let's get into data interpretation a bit more. Next slide. So what do we mean when we talk about data interpretation? And simply, it's a process for making sense of the information. So if you remember from last week, if you joined us, we talked about how analysis is a process that moves us from data to information. So once we arrive at information, we need to make sense of it by looking at connections and comparisons and exploring causes and consequences. The WHO Toolkit provides a 4-step guide for interpretation that you can work through with your teams. You start by looking at the relevance of the finding, asking your team questions like, what do the data tell us? And what does this mean for our programming? Have we met our program targets? Are levels and trends for our indicators higher, lower, or about the same as previously? And from there, you'll ask why. Why are we seeing these levels and trends? Think through possible reasons for changes in the performance of indicators with your team. Then it may be helpful to consider other data that could be used to help understand your data. So think about whether there are other data that could be explored or other people who could be brought in to help explain the data. Finally, you want to think through any remaining questions and how your team might answer them. Are additional data needed? Can any of the answers be, the questions be answered with more analysis on the data that you already have? Are there other actions to take to answer these questions? Supervisory visits or stakeholder meetings, etc. And then to this graphic that the WHO provided, I would add the arrow below, indicating that stakeholders should be involved in this process where possible to help brainstorm and provide the essential context. I think having stakeholders involved in interpretation is really important and very, very useful when it can be done. Next slide. Now, let's cover some key questions and considerations for data interpretation. When looking at data, not only is it important to have your teams look at what the data are telling you, but also what the data are not telling you. For example, in the graph here, it's showing mock data that we pulled from the WHO Toolkit. We have stillbirths as a proportion of all births in facilities, that is quarterly, from the beginning of 2021 to the end of 2022. So when we look at this, can we tell what proportion of all births in facilities were stillbirths? Yes. Can we tell what proportion of all births overall were stillbirths? No. So this doesn't tell us anything about births or stillbirths outside of facilities. Can we look at the proportion of stillbirths in facilities that happened in the intrapartum or antepartum periods? Yes. Can we look at overall facility stillbirth trends over time? Yes. Can we talk about trends from before 2021 or after 2022? No. Do we have any idea of reporting completeness from this information? Also no. So while we can get a lot of good information from this graph, it's important to think about what we can't say. I actually honestly prefer to kind of think about what we can't say first when I'm looking and in trying to interpret a graph, because it usually helps me to keep me from saying those things. So the WHO Toolkit provides a number of these examples that would be useful, I think, to look at with a team when discussing interpretation. Talking through what you can and can't say about the data you're looking at could be a nice warm-up activity before looking at your own data. The toolkit also goes on to provide some considerations for data interpretation that might be helpful to work through with your teams, including making sure your data are standardized. So looking across and checking that the data share consistent denominators, units, and population bases, particularly when comparing data across different groups or time periods. Then considering the impact of data quality. Quality has come up every single week of this series thus far as a very important consideration for analysis and interpretation. I recommend reviewing data quality metrics where they're available, and include these in the interpretation, and just be really honest about the limitations in the data. Remember that correlation does not mean causation. Other factors are involved and may influence the relationship. So poorer health outcomes in rural areas do not imply that living in a rural area directly causes these outcomes. Lots of other things like access to health services, health workforce density, etc., can have an impact on health. So be careful to give this careful consideration when assigning attribution. If you need to illustrate this point to your teams a bit better, I highly recommend the website that Zach is going to put in the chat right now that illustrates these spurious correlations a bit better. Or there's this publication that suggests a relationship between margarine or butter consumption and divorce rates in the US state of Maine. Some of these examples are quite funny, but I think they also help illustrate an important point that even if you see correlation in data, that it's not always causation. So next, consider the generalizability of your data to the entire target population. This is also a very important consideration. If your data are taken from a distinct source that only represents a portion of your population, say births in facilities or births in public facilities, you can't generalize those findings to everyone because you're missing births in non-public facilities or those taking place outside of facilities altogether. Be careful drawing broad conclusions based on a limited or biased sample size. Even with routine health facility data, the data often just reflects services provided in health sectors in the public sector. Then review data or information supporting various factors or outcomes. Don't look at and consider only the outcomes that support your conclusions. In English, we refer to this as cherry picking data. So I have my graphic of the guy picking cherries. You have to look at it all holistically, including contradictory evidence, in order to interpret the data more fairly. Finally, be honest about the limitations of your data. As we discussed last week, it's really important to acknowledge that there are often limitations to data and analyses, and it's best to be very clear about those so users, like decision makers, can take that into account when they're interpreting. So that's a brief overview on interpretation of data. As always, the WHO toolkit goes into more detail than we have time to cover here. But I think our presenters will also talk through interpretation, and I really want to make sure we have plenty of time for that. Next slide. So again, very quickly, we'll touch on supporting the use of data for decision making, and then I will turn it over to our presenters. Next slide. So I probably don't have to explain to you all why data are important for decision making, but I thought this was a nice quote from the WHO toolkit to include. We definitely want to be making policy and programming decisions based on empirical data versus just arbitrarily. So what are the key elements of a data-informed decision? Well, first, there are the data and information themselves. There can be lots of sources of data and information we use for decision making, from the national to facility level. For some examples of different data sources, you can refer back to last week's session, but all relevant sources should be considered when making decisions using data. The next key element of data-informed decision making involves the person making the decisions, the stakeholder or decision maker. This is anyone who has an interest in the decisions being made. Finally, there's the process of the decision itself. Generally, there are 4 types of decisions that we work with. Decisions to inform program design and evaluation, decisions around program management and improvement, and decisions for strategic planning, and then decisions for advocacy and policy development. All 3 of these elements, the data, the stakeholders and decision makers, and the decision itself, are important components of the decision-making process. Next slide. So the WHO toolkit lays out some steps for using data for decision-making that it might be helpful to talk through with your teams. So the first step is to review available data and information and identify issues for investigation. Ask yourself what the question or problem statement is after reviewing the data. Really consider the accuracy of the data or information and think through what other complementary data or information are available for validation or triangulation. And see the last session for more information about triangulation. That leads us to our next step, assessing what additional data or information are needed. What other data or information do you need to investigate the issue further? What questions do you need to ask and who should you ask? Then you'll want to define changes with root causes. You want to describe high-level changes being seen, and to do that, you'll need to look at the root causes of the issue you're investigating. Think through how you can investigate these root causes. Our Momentum Country and Global Leadership colleagues will talk a little bit about the root cause analysis tools they use, like the 5 Whys and Fishbone frameworks, in a little bit. Then you'll need to identify stakeholders, considering who should be involved or consulted as part of the data use process. Who has interest in the identified issue? Think through the optimal but also realistic level of involvement of these stakeholders. So often, we're often bound by time and resources, and the optimal level of involvement isn't always possible. Finally, develop recommendations and/or an action plan. What are your recommendations? What do you want stakeholders to do with the final information that you give them? What's your timeline? What are the additional questions that remain, and what steps can be taken now? The more actionable your recommendations, the better. Next slide. Note that although the process is displayed as a linear in the graphic, using data for decision-making should be an ongoing, continuous, and purpose-driven process. You also shouldn't be surprised if increasing the demand for data results in the need for more data collection, and if asking questions leads to even more questions. I feel like it's a rare occurrence when data collection thoroughly answers the questions with no additional outstanding questions. It's a nice idea, but I've never had that happen. So in the context of MNCAH, some of the questions you can use data to answer might be looking at whether or not you're on track with your activities, gauging if the population's needs are being met, providing guidance on where to concentrate your efforts, demonstrating that you're meeting targets, and identifying where to invest more resources, and then determining whether your program objectives have been met. Using the data to guide programs and policies, but also to feed back into the program for program improvement is very important. If you've worked on USAID-funded projects before, you may kind of be seeing some similarities between this guidance and the continuous learning and adapting cycle. We'll talk about that in some of the resources that we highlight in this next section. Next slide. So now we'll briefly highlight some of the important and relevant resources that address data interpretation and use that can be used to support some of your teams. Next slide. As I mentioned earlier, today's content is adapted and pulled from modules 5 and 7 of the WHO toolkit, if you're looking for more resources on data interpretation and use. Next slide. The toolkit is really nice in that there are exercises that can be used with your teams to practice the concepts that are presented, many of them using data and case scenarios. Next slide. Next, Momentum Country and Global Leadership has put together the Momentum Data for Action Guide that helps guide the data for action process that Mary will discuss in a bit. There are also some helpful templates and agendas that can be customized and used to meet your needs. Next slide. Finally, I want to highlight 2 of the adaptive learning resources that Momentum has put together. We have the Adaptive Learning Guide, which provides more background and context around adaptive learning. We also have the toolkit that Momentum Country and Global Leadership put together, which provides more detail about some of the specific approaches that might be useful to some of your projects. They are both linked here, but I just want to note again, unfortunately, that all of the resources here that I've presented today, including the WHO toolkit, are in English only. If you have good resources in French for data interpretation and use, please feel free to drop them in the chat to share with others. And perhaps, as I said last week, we could update the resource section of the presentation if there are some good interpretation and use resources available in other languages that focus on MNCAH. So with that, I would like to get into our exciting presentations. First up, we'll hear from Scott, MNCAH, and Tapson from Momentum Country and Global Leadership to talk about their work mapping routine MNCAH data and using it for decision-making in Nigeria and Zambia. So Scott, I will hand it over to you.
All right, thanks, Emily. Okay, so far, how is everyone doing today? So thank you guys for joining us. We appreciate you being here. And we're looking forward to talking about what we've done in MCGL. And so as we look at all of this stuff, we just want to say that we've spent some time talking about data interpretation and some references to visualization and use. Ways to visualize results from health facility data resources and using that visualization process to guide decision making. What my colleagues at MCGL wanted to do was to go deeper into one special type of data viz, one that often gets overlooked or left aside, often out of fears of misuse, misinterpretation, or technical barriers to entry. But we at MCGL have found this to be, accessible, essential, and deeply useful for all of this, not just for understanding and visualizing our data, but for driving towards action. We're talking about, GIS and mapping. And so when you open up the WHO toolkits or any of the WHO guidance documents, you'll find maps, data maps that look just like this. Here, for example, we have maps on ANC attendance, on vaccination rates, on newborn health. Maps frequently appear when we're talking about data use for health programming. Okay, next slide, please. Okay, so why maps? This shouldn't really be a surprise. Health workers have been using maps to understand the results and to drive interventions since at least as far back as 1834 with the cholera maps in London. And there's a few reasons why this is the case. Next slide, please. One of those reasons is that using maps, oops, sorry, can you go back? There we go, thank you. Using the maps and GIS data sources, help to bring us data together using location as a common thread. That can help us to better understand our data in context as we're looking at all of these possible layers that you see on the slide here. It can help place our results in the context of population, poverty, demography, settlement data, all of those various different resources that we talk about adds context as we're thinking through all of this. Next slide now. Thanks. But as we talk about this and we look at these results, there's a whole science that we don't have time to get into, but I'll just use an example, these 3 5x5 grids. They are different distribution of data spatially, but if we plot them in a bar chart, we get the exact same number of squares. Using a map helps us think about the distribution of results and understand how that data and the programming and the working that we're doing is distributed in space. Using GIS and mapping helps us do that. As you can see, the distributions quite differ in those 3 grids. Okay, next slide, please. Okay. So we've been using maps in MCGL to integrate GIS into our work in a few ways. We've conducted facility mapping exercises and created standardized data sets. Across all of our MCGL work that we work to make sure that we have this data available to access and use, and people have accurate location and data for all of their mapping. We then use this to create maps of our activities, maps of where we're working, maps of relationships between various sites. We've then done things to do like calculate catchment area populations, calculate measures of access. But above all, we've used our maps to visualize results, identify trends, and see clustering of results. Next slide, please. The maps help us visualize RMNCH data in a few ways. We can think about our RMCH data by sites or by districts using different types of maps. So for instance, here we have chloroplasts that are filled in by district maps. We also have the bubble maps that show relative size of various indicators. Okay, next. Okay, so we can also look at a single indicator on a map or multiple indicators on a map. In this case, we're using two indicators together and using shading to tell the relationship of those two indicators. Even more, we can go a step further into developing composite indicators, but we have to worry about complexity. Next. Okay, so we can think about maps as a single data point or a time series in really compelling visual ways. So here we see, data over time of just a single indicator. Okay, next. We can also think about maps in terms of raw values or computed through spatial statistics. So these are hot spots and cold spots doing relatively advanced calculations to try and help determine where we should focus our programming. Next slide. And so what we're going to do in this presentation is to deep dive into two examples of countries that have used maps to not just to understand their data, but to drive responses as well. We're going to work with Nigeria and with Zambia, but we're going to start with Nigeria first. And so right now I'm going to hand it over to MNCAH to take us through an example that we did in Nigeria. Thanks, everyone.
Hi, everyone. Good afternoon, good morning, good evening. All right. So the title of our case study is Mapping to Support GBV, Gender-Based Violence Response in Ebonyi and Sokoto States, Nigeria. Next slide. So the MCGL GBV project had an overview to prevent and mitigate consequences of violence against women and girls, to address possible drivers of child early and forced marriage, and promote early adoption of family planning. We had 4 objectives. One was to build capacity of host country institutions, the local organizations, and providers to deliver evidence-based, gender-based violence, child early and forced marriage, and voluntary family planning services. Objective 2 was to increase access to and use of evidence-based quality intimate partner violence, sexual violence, child early and forced marriage, and family planning information services. And 4 was to adaptively learn and use evidence in gender-based violence and child early and forced marriage programming. And 4 was to facilitate cross-sectoral collaboration and innovative partnerships amongst the state and non-state organizations who work on IPV, sexual violence, and child early and forced marriage. So the implementation was, the program was implemented in 2 states in Nigeria, Sokoto and Ebonyi states, and we supported 238 healthcare facilities across board. And the constituent partners were Japaigo, Save the Children, the Man of Group, and the Pact. we implemented from October 2020 to September 2024. And we didn't implement directly, we implemented through the local partners, 3 in each state, 3 DoveNet in Ebonyi State, EQs and EHN. And so in Sokoto State, we had Nana Girls, Helping Hands, and Rural Women and Youth Development. Next slide, please. So data from the Nigerian Demographic and Health Survey tells us that in Nigeria, 36% of ever married women have experienced IPV. Likewise, it also says that 53.9 and 35.4% have experienced IPV in Ebonyi and Sokoto states, respectively. So when MCGL started, they commenced with a formative assessment in the 2 states by evaluating the gender norms in the states, social norms in the state, and then the political governance norms in the state as well, and the governance analysis, and finally doing a gender-based violence services mapping. At the end of it, we co-created with the stakeholders to design the project, to design the intervention. At the end of it, we came up to build the capacity of healthcare providers or the facility, and engage communities using proven gender transformative approaches, and also building capacity of local institutions and multi-sectoral response and stakeholder engagement. Next slide, please. All right, so prior to MCGL, there was no screening done at any primary health care centers in those places in the states. So MCGL trained healthcare providers on post-GBV care, and subsequently, the healthcare providers now gained knowledge on how to screen, and they screened at the outpatient department, ANC, and the family planning. So clients who disclosed gender-based violence were referred to trained providers. And these trained providers provided post-GBV care. And at the end of the day, it improved the health outcomes by preventing HIV and improving the safety of the survivor, and the survivor eventually received care. Of course, you can see the service flow where if a violence is identified, the survivor will be provided with first-line support like listening, inquiry, enhanced safety and support, and then other needs are being provided. Next slide, please. All right. So when GIS workflow, we try to collate enough data, GIS data mapping, GIS points. So we use the REDCap to get the data for data collection and extracted it onto the Excel, and we had to validate it using the secondary data set like the DHIS, the Google Earth, some government website. Doing this was essentially to improve the quality of our data, and some facilities with missing points we are repicked with using the Kobo Collect and then WhatsApp geolocation tool, and eventually it was validated. And then these validated validated site lists were now used in developing our dashboards and doing analytics on the Power BI. Next slide. So what is YMAP? The key visuals for data for dashboards. So the team aimed to visualize GBV case identification data using interactive dashboards for monthly data review meetings. So this approach allowed us to effectively track and analyze the trends across different sites and other subnational units over time. When we presented this data in a clear and dynamic format, we were able to easily identify patterns like increases and decrease in case identification and make data-driven decisions to inform future actions in the intervention. So our dashboard provided a comprehensive overview that enabled the team and the stakeholders to monitor performance, and we assess the effectiveness of our intervention and ensure that some of our resources are being directed towards the areas with the greatest need. So the next slide. Yeah, so you can see the MCGL project implementation dashboard. So you can see that the period is there, the states, the LGA. So on the left part, you can see that there's GBV screening over there, the case identification. So when you click on any of them, it's able to bring out the numbers that you need, and then the map is showed, and then you are seeing the site straight from here. Next slide. All right, so we were able to, this is just a sample of one of our facilities, Gidan Dahala Primary Healthcare Center in Sokoto State, where it points out where the facility points out the total cases identified, showing that it's 621. So in doing this is just a sample. All the sites were able to know what is happening in each of our 288 facilities. Next slide, please. All right. So we also wanted to understand high GBV case identification. So locations with a high rate of gender-based violence case identification, the team, we aim to investigate the underlying factors contributing to these trends. It helps us we were able to examine specific practices or approaches that were used by the healthcare providers that may influence the identification of cases, as well as we try to analyze the socioeconomic dynamics and the cultural norms within the communities which will be driving the increase in some reported cases. So we gained a deeper understanding of these factors, and we tried to identify the root causes and then developed tailored ways or approaches to address some of these challenges. And at the end of the day, it's improved the GBV response in the area. The next slide. All right. So this is one of our mappings that we used, our density mapping that we used using the QGIS. So here we try to use a color grid to illustrate places with a high density with a high caseload, GBV caseload. Like I can see in Ebonyi State here, Eza North and Abakaliki, which has a darker grid, is having a higher caseload, while some of the rest are having lower, as the case may be. And Ebonyi was having lowest, and of course Afikpo North was also having the lowest caseloads. Next. All right. So the data, one of the reasons for mapping is for data to action, taking our data into action. So data from all of our dashboards and maps, we try to analyze and utilize them to inform the planning of our next steps. The process, we try to identify specific areas that needed improvement, and it led to scheduling of targeted mentoring visits, supportive supervisory visits to provide direct support to providers. And at the end of the day, we try to hold on or organize refresher trainings for underperforming regions to address gaps in performance and ensure that the staff and some people and stakeholders, of course, were equipped with the necessary skills and knowledge to meet the project goals effectively. Thank you.
Great. Thank you, Emeka. Can we now turn it over to Tapson Nyondo, who will present on GIS for maternal and child health in Zambia? Tapson.
Thank you very much. just as an introduction, one of the key questions that led us to decide on GIS was a question from our donor that kept on coming. How does a district wide approach looks like? We say we are supporting all the facilities in the 6 provinces, but the question is, how does it look like? But also looking at the resources that we have, can we be in every site that we need to go? Therefore, what do we need to do to decide to go to prioritize the sites that we need to reach? We have over about 2,000 facilities, and that means that not all the resources we have can reach everywhere we need to go in terms of reducing maternal and child health. Next. With that in mind, as you can see, we're in 6 provinces in Zambia, and these are the provinces we are supporting, and we have around 2,000 facilities that we are targeting. And every district, we have about 72 districts, and all the districts were expected to ensure that every facility has a support from our projects. That brings us challenges. How do we reach all the sites, but also have an impact looking at the resources that we have? That's why we thought GIS could be a key tool to guide us doing that. So you can see we're reducing maternal mortality, but we're also expected to reduce under 5 mortality. Next. So one of the key things was to how best within the district, how do we place the resources? And taking advantage of the ministry's structures and using a zonal mentorship model. So you can see at the top of the district, you have the district health office, and I think it's similar in most countries. And under there, you have a zonal hub. So in a district, you may have 3 to 4 that looks at different sites, centralized sites that fits into the zone. Using the mentorship from the district, sometimes you may not reach all the sites, but you need to make a decision to see which zone hub is more closer to the satellite for continuous support to them. So you can see different sites, 4 to 5 in each district. So in a zone, in a district, you can have 4 or 5, and those hubs that are critical to support the process. So when we define those structures, it became easy for us to say, how do we apply now GIS across the district, but also across the provinces that we are supporting? Next. So now that's now the issue of, as you saw, the one of the goal is to reduce maternal death. We have over 2,000 plus facilities. The question is, where are the most deaths happening? Is it every site? Is it concentrated in few sites? When we use the GIS map, it showed us that where you see the bigger it is, the bigger the high volume in terms of maternal death. So as you can see, we're able to map the high volume, but also the low volume using the existing data that is in DHIS2, and that tells us where there's a concentration and how best do we now resolve that. But while we're resolving that, we also know that there are also referral systems. Not all the deaths that happens in those high volume have issues. Some of them is because of late referrals from the central sites. So how do we resolve those issues to make sure that at the end of the day, we target our resources, but also we fulfill the whole district approach according to the expectations from our donors. Next. Then with that, we're able to use GIS to identify the hotspots. As you can see, where there's a red, those are the hotspots. Therefore, those are priority sites and districts that the resources can move to. But not forgetting that where also you have also other dots, you also need to target because you have a whole district approach. But in terms of moving resources and targeting, you focus on the hotspot where it's happening more in terms of maternal death, but not forgetting that you also have a whole district approach that also need to be catered. And also you have a referral system that is feeding into those hotspots. Maybe they also need to change certain behavior, or maybe referring quickly, or they also need some skills that should prevent them to refer frequently, even those conditions that are supposed to be resolving on their own. Next. So when you look at that, we identified priority district based on GIS hotspot data, but also structure and targeting facility mentorship and quality improvement. So one of the key high impact interventions that we have, but also over time, both from JAPIGO and also in country, quality improvement are very critical. The moment you introduce them and properly designed, you would see that there's changes in this immediate impact because it mobilizes people to work together at a facility where there's a hotspot and ensure that they devise strategies that should be able to support that. And that is identified by GIS. And some of the elements that comes in is mentorship. Next. So what you see here is mapping the network. Where is the mentorship hub? Yes, you have identified hotspots. How are you going to, what is the relationship of the set site? How best do you capacitate even facilities that are referral to the hotspot? And how are you going to anchor and sustain those services? That's why the hub comes in, but also ensuring that the hubs are supporting the whole system. Yes, you are focusing on the hotspot. Yes, you are focusing on the high volume, but how do you ensure that you also capacitate the referral system, in a referral system that is pushing the numbers to the hotspot in such a way that if they're lacking skills, they should be able to have skills that should be able to manage the pregnant woman before delivery in a condition that is salvageable at the hotspot. In that way, yes, you are concentrating the resources at hotspot, but also you need to focus on the referral system that is critical because a hospital, a facility will just be referring people to the hotspot and people are dying there. While we are thinking that the issue is not, the issue is at the hotspot only, but also where they are referring more. And who targeted that is the mentorship hub, which is closer to the set RHIS that are referring the numbers there. So that's why you can see we're able to design the relationships to ensure that the whole process is foolproof, but also prioritizing the resources to make sure that you meet the needs across the tier system in terms of the referral system. Next. Over to you, I think, Scott.
Yep, this is me just for a quick wrap up. And so as we've talked about this, and so what have we learned from these individual countries in the program as a whole? So first, there are, so many data quality challenges that we have to deal with this, as Emily mentioned in the beginning. In addition to regular data quality challenges that we have in routine RMNCH data around timeliness and completion, when we bring in the spatial dimension, we also bring in new challenges around data quality. It's around accuracy of locations, consistency of naming, appropriateness of precision, consistency of references, and on and on. These are new additional challenges that mean the way we're thinking and trying to address these issues, this can't be taken lightly. Okay, next bit. Okay, so what we learned fairly quickly is that there is some caution needed in interpretation. Some of these GIS concepts that we're working with, like when talking about hotspots and when we're thinking about how do we meaningfully compare areas of different sizes, there are truly correct and incorrect ways to read a map. And that means often just taking the time to walk a data user or decision maker through the information that's critical that we need to spend extra time, considering. Okay, next bit. And so, but despite all of that, we strongly feel, and we found that using maps provides an opportunity to understand our results and our context together in new and better ways. It's an essential tool in our armory when we're thinking about it and taking a data-driven approach to programming and management of these programs. So thank you very much, and we'll pass it back to the next bit of the team.
Thanks, Scott. Hi, everybody. My name is Mary Drake. I'm a senior monitoring and evaluation and learning advisor, and I'm really pleased to be here with you today to share our data for action guide to improve our MNCAH program performance in low and middle income countries. Next slide, please. So I'm going to start with an overview. Essentially, the basics of the data for action meetings. What are these for? They're really to review progress that is made on a small set of prioritized indicators, to review and give feedback on the quality of data, and really to help drill down to the problem or root cause, to help generate concrete follow-up actions. And there are some guiding questions. We'll talk more about those in some of our country examples. And there are some tools which are included in this guide that can help kind of get this work going or continuing. So those are laid out here. And I just want to say that this process, data for action can really be integrated through it. It's intended to be integrated throughout the program lifecycle. There's no bad time to start doing this. All right, next slide, please. How to use data for action meetings. So there's a preparation phase, and there's conducting the meeting and some follow-up. So it's really important, like any other kind of meeting, set the objectives. For this data for action, selecting the indicators is of high importance. I'll talk more about that in a minute. Organizing the team, preparing visuals, and doing the best to resolve any data quality issues in advance. Describe the trends. And there are some tools that are listed here on the right, which are part of the data for action guide. There are some sample indicators, stakeholder mapping tool, data interpretation tool, and a sample agenda. When it comes to actually conducting the meeting, this is where it's good to have prepared in advance a description of the trends and identifying any gaps and outliers. And then really to spend as much time as possible on analyzing the root causes that are kind of underlying the trends that are seen, and developing an action plan. And anytime, this is not the first meeting, it's really important to check in on what actions were developed previously, what is the status of those actions. And there's, again, some tools, a data interpretation tool, the root cause analysis template, and an example, and then an action plan template. Next is about really implementing the changes and tracking progress. Next slide, please. This is essentially, kind of another way of describing the process. One thing is really, two things I want to point out here are there are specific roles in this, phase of conducting the meeting. It's important to assign roles in advance and have people prepare for those roles so that this session could go on well. So the facilitators, the note takers, the timekeepers, and then, documenting the findings and the process and the findings during these meetings really helps to ensure, follow up more. It's more easy to follow up and track. All right, next slide, please. All right, so I'm sharing with you, experience using this data for action guide with our work in Indonesia and in Zambia, and a lot of input from this work. And one of our key things when we were working on this in Indonesia was there were quite a number of indicators, and there was initially some work done to try to address all of the indicators at once. And there was then kind of a step back and think, how can we really, it's not sustainable to go looking at so many indicators every single time. So we did some work together to help prioritize indicators. Next slide, please. So what are some ways to prioritize? A key one is that an indicator really needs to show variation over a short time span. And, indicators that may change over a longer period could be acceptable, but within the, program lifespan that you could expect to see changes. Also, the indicators need to be reliable, valid, easy to understand, and data, it's easy to collect. And then to the extent possible that it's presented in a granular fashion, so that helps facilitate comparing between operating units. So facility, to facility or district to district, to try to really look at what trends there are, what changes have been tried, and what are we learning from each place, and that we could bring to bear on other locations. Next slide, please. It's important that indicators to be selective in choosing the indicators. And this is important conceptually, and definitely when it comes to actually implementing this process. There will not be enough time to review every indicator, do the root cause follow-up, root cause analysis, develop an action plan. So in general, in a one-day meeting, 3 to 5 indicators can be discussed. If there's another half day, some additional indicators could be added, 6 to 10 indicators. There are, example suggested indicators in the guide that draw upon the WHO guidance that Emily spoke about earlier, as well as maternal and newborn health programming that has been done through the years. And these indicator lists really need to be adapted to the country context, and to the extent possible, be able to be drawn from the national HMIS. Next slide, please. These are a couple of the indicator lists. Just wanted you to know that these are in the guide. Next slide, please. All right, now we're going to talk about a little bit of data interpretation. Next slide. The guide has some examples. So this is an example, and what I want you to notice about this slide is that there's a visual, and then there's kind of a table with interpretation. So first, within the visual, you can see that there's a target line. There are numerator and denominator data, and then there's a percentage data charted on here. And some of the questions that are asked that are important to ask about to understand some of the trends is there the performance of the indicator staying the same over time, or is it changing? If it's changing, why? Is there the performance of the indicator changing in a similar or opposite ways compared to other related indicators? And do the trends show that care is improving, getting worse, or staying the same? And then, so looking at this specific, visual, you can say there's an upward trend from the 20s range up to the lower 40s to 50s in the percentage of women giving birth at a health facility. And then during, this May to July 2020 period, there was a true low number of women giving birth, and also a very low estimate. And then August 2020 to December 2020, the number increased, the number of women giving birth in a facility increased, but also the estimate doubled. And then we have for January 2021 onward, like a stable number of births, but the estimate is fluctuating. I know most of you on the call probably are really familiar that estimates really can change and it can really affect what your performance looks like. And these estimates, you know, it's important to have that context when you're using an estimate for a denominator. So next is kind of the discussion on those, you know, after discussing those numerators and denominators and trends, like what do those trends really mean? Looking at what is the problem, what could be contributing to the problem, and then going on to brainstorm actions. Next slide, please. All right, so when it comes to actually trying to dig down into the root cause, in the Data for Action guide, we have two approaches that we're really using as illustrative approaches. Next slide, please. One is the 5 whys and the other is the fishbone. So to really understand multiple causes of a problem, a fishbone is helpful. And when you want to try to understand drill down to maybe a single or a few underlying causes of a problem in depth, the 5 whys are really helpful. Next slide, please. All right, so let's talk about the 5 whys. So it helps to understand why something is the way it is, and then, you know, helps, you know, to drive down. So 5 whys indicates or refers to your first question, like you ask why, and you ask why again and why again. So here's an example. Mothers are not breastfeeding. So why? They feel uncomfortable taking their gowns off. Why? Well, the gowns open at the back, so they have to take the entire gown off to breastfeed, and they feel uncomfortable. Why do they have to have this type of gown? That's what the storekeeper orders. And why doesn't the storekeeper order gowns that would be appropriate for breastfeeding? Because nobody has requested him to do that. Now, an alternative scenario to this same kind of 5 whys is mothers are not breastfeeding. Why? They feel uncomfortable taking their gowns off. Why? There's no privacy, so they feel exposed. And why is there no privacy to breastfeed? They're in a common ward. There are no curtains or separate covered space. So each of these would lead to a set of actions then, which could be included in an action plan. Next slide, please. And in the Data to Action guide, we have some other examples. And I want you to know that there are these resources available where you can look further into the 5 whys. The first is really more of an industry kind of 5 whys general description. But it's good to get like kind of wrap your head around this approach. And then the other, which I think is really relevant to our work, is from the Institute for Healthcare Improvement, IHI, which, you know, does a lot, like is a leading kind of organization in quality improvement and root cause analysis as a part of quality improvement. Next slide, please. All right, so now talking briefly about fishbone. With the fishbone, it's good to identify multiple factors that could be contributing to a problem, and you know, it's recommended to group them into the 4 Ps: people, places, procedures or practices, and policies, and then anything else. Next slide, please. So I've already described that we talk about these 4 broad categories. The reason it's called a fishbone is because of the image. So there's this long horizontal line with the problem as kind of the head of the fish, and then the people, the places, the policy, and the procedures kind of coming off the sides of the spine. Next, please. Here's an example with the problem being a delay in the treatment of sick babies. In the procedure kind of domain, one part of this problem is that there's not a process for restocking an emergency tray. And then when it comes to place, the same tray contains emergency and assessment supplies. So it's not only including emergency supplies. In the people domain, staff are unaware of the importance of triage. And in the policy domain, there's no unit policy for triage of newborns upon arrival. So all of these, that I've highlighted, plus others here, are contributing to a delay in the treatment of sick babies. And from here, again, very specific actions could be developed and implemented. Next slide, please. This is another example that's more on health workforce for reference. Next slide, please. All right, so here's an action plan template. The columns here start with the indicator, then what are the actions that would be taken, the responsible person, and the deadline. Next slide, please. I also just, again, want to emphasize the importance of documenting to help with easier follow-up, and also really extracting from the entire kind of the series of data for action, sessions, what has worked, what has been tried, what has worked, what hasn't worked. Next slide, please. And these are some of the key roles. All right, next slide, please. All right, now let's get into some examples. Next slide, please. All right, so this is from Indonesia, where, as I mentioned before, there was a good amount of work really on adaptive management and learning, indicator selection, and then implementing an intervention called hospital mentorship as a part of quality improvement in facilities. And there were facilities where hospital mentorship was completed, and this was considered 3 visits was considered complete. And there were other facilities that did not receive hospital mentorship. And the sites that were prioritized were higher volume, lower performing sites. And so you can see from this visual in green, there are we have two indicators that are presented here. The top is where we'll start, institutional maternal mortality rate ratio. So this is of all those births at the health facility, women who were delivering, how many died while in the facility. So we see in green, those facilities that had hospital mentorship have started with a high institutional maternal mortality, and over time, there was a reduction. And as compared to those facilities that didn't receive hospital mentorship, the IMMR started at a lower level and slightly increased. And additional, similarly, that same trend is seen for institutional newborn mortality. So this is helping us to understand, this intervention has actually, has a contribution to a reduction in maternal and newborn mortality. Next slide, please. Sorry, can you go back again to the previous slide? I also want to say that, this is kind of the end result of a lot of work, and part of this process was a deep dive into hospital mentorship, what was working and what wasn't working, and seeing, some components of hospital mentorship that worked better, that were integrated into the hospital mentorship model across all facilities. All right, next slide, please. All right, and here we have an example from Zambia. This is another way of kind of presenting some of the data. First of all, really deciding documenting in the left-hand column what the indicators are with the numerator, respective numerator and denominator, stating why is this indicator important, and then really preparing in advance, what are the questions that you are going to ask based on the indicator performance. And then here within the data visualization, you can see that there's some key elements. There's a national target, there's a project target, there's a quarterly target, there's baseline, and then you see the trend, because often we just see trends. We don't really have the context of what the target is, or what the project target is, what the national target is. And then and for this particular indicator, we have seen this family planning, postpartum family planning, really be difficult to improve. Yet the national target is 60%, and we see rates much more around this, like 8 to 12%. And we have not changed our project target to match the national target because we feel like it's not it's not entirely realistic, and have engaged with the ministry and USAID around this point. And then the other key part of this, visual that I want you to notice is it's annotated with some interventions in green. So you can see the integration of immunization and family planning was done. Also, there was orientation of safe motherhood groups and community-based distributors. Then there was mentorship and deployment around of the new registers to improve documentation. So what kinds of things were done here? What was noticed? There was low uptake. It was definitely lower than expected. There was some improvement over time, but it's still well below the target, and there are some fluctuations. And so here on the far right, some actions that have been taken over time to help address the performance. Next slide, please. This is more or less a summary of what were some of the types of actions that were taken in Zambia during a Data for Action meeting. That these were developed, and these will be available to look at in more depth. But I want to point out that there are things that are internal to the project, some things that are external support to the ministry, and that the types of actions are really a wide variety. Could be related to the health system, experience of care, community engagement, health worker performance, or related to data quality. Next slide is a short checklist, which we've used in the Zambia program to help in the preparation of the visuals, also in the interpretation, and then really to help develop actions for that kind of encompass what might be across, internal to the project, external, also where to focus geographically, and those actions related to data quality. So it's a way to kind of check, have we thought through, the various things that may be at play here. Great, next slide, please. All right, so just like to wrap up, it's good to build on the adaptive learning basic toolkit, particularly the intervention description. That exercise and the intervention description is really important, can help to guide the root cause analysis and discuss factors that strengthen or weaken the indicator performance. Next is that the indicator selection should not be taken lightly. It requires a difficult task of prioritizing some indicators above others. The first kind of data review meetings often have more data quality issues, but don't get stuck on only addressing the data quality issues, because using this data helps to drive the improvements in the quality and in the program. So sometimes there's this temptation of like, we don't want to start using presenting this because there's so many issues. Sometimes presenting it, and the approach behind this data for action guide is presenting data as it is, even with its issues, helps to, you know, really drive up quality of the data. So earlier identification of issues, rapid intervention to address data quality, and, you know, use this data in ways to help identify root causes and improve performance. Yeah, share and use the tools and templates. So, you know, this is something that should be accessible to everybody. It's not required that it's like closely guarded. And then digesting the data, like really having sessions to digest the data prior to going into, you know, the kind of fora for the discussion is really helpful. There are some there are lots of busy people, and looking at data and understanding what it says might not be their top priority, or it may not be a skill set that they're comfortable with. So it's also that some of these earlier sessions can take more time. And then the root cause analysis is really, it's the hardest part. It can take several discussions to develop the skill. And then once that's developed, subsequent sessions do go more quickly. And it's also kind of an area where it's uncomfortable because it requires kind of, you know, it really requires having a learning mindset, that we're not trying to like point out things that for the sake of blame or, you know, putting something on someone, but really to help improve whatever problem we've identified. Okay, next slide, please. I'd like to make sure you all know about these resources. They will be available in the presentation. And then next slide, please. I'd like to acknowledge, you know, a lot of the MCGL staff who are included here in the, you know, on the call, including Bunrul, Pagali, Jim Recca, Alex Chanza Mubanga, and Luis Ortiz, who is our knowledge management person. We have had a lot of input on this guide and process from USAID and MNCAH, JPIGO, and just really appreciate the work that people have done. And this builds heavily on, you know, Data for Impact project, which developed a guide on displaced children and orphans fund in Uganda in 2021. So really acknowledging the good work that was there, that we've built upon. All right, thank you so much. Really, really appreciate the opportunity to share with you.
Thanks, Mary, and thanks to all of our other presenters for these really interesting and thought-provoking presentations. And thank you to all of the participants for your interesting and engaging questions in the Q&A. We've had a lot of interesting questions, and our GIS team has kind of been able to address a lot of those in the chat directly. But we do have a few minutes here for some live Q&A and discussion. And I think, Mary, I'd like to kick the first one over to you. There's a question that came in that asks, what's the best frequency for a data to action meeting, and how long should each meeting last?
Really, the best frequency is every month. And that means it could be a shorter, you know, like a 4-hour or 3-hour meeting. It's still a lot of time, but they start off being about 3 or 4 hours. They could get shorter. Thanks.
Great, thanks, Mary. I think the next question, I'll kick one over to Scott, Amika, and Tapson of, do you have any lessons learned or tips for supporting local partners to incorporate GIS into routine monitoring for MNCAH activities?
Tapson, do you have any thoughts on this? I mean, I can start as I talk about this and as I think about this. And I mean, going and building off of what Mary said is, I mean, is start out by just making and being intentional in doing it. And so as you start doing it, we are true believers in this is going to be hard, but the reality of working on this is better than the alternative where you don't. And so the specific, processes and all of those very much depend on your given context and your given environment. But it's always felt like once you start this process going, the conversations we've seen have been just so fruitful, and you build from there as long as you're listening to your users. Do you get Tapson or MNCAH or Mike, do you have any more to add?
Yeah, so I think in our case, I think it has been an issue of you keep on getting questions from different stakeholders, as Scott mentioned, the users, and but also within internally, you also observe that every staff officer is focusing on their areas. So the questions that people keep on asking, they're being answered from a perspective of one staff. Now, how do you bring these all perspectives together? And that's how the issue of we decided to do that, and it brings that kind of where even if a staff is involved in community, but as long as you have a perspective which is one and is focused, you find that GIS does bring that. So there are a number of considerations on that, but key thing is how do you respond to the questions that the donor is asking, what the staff are asking, in a way that is comprehensive and support the whole process moving forward. Thank you.
Thanks all. So we are coming up on time for today's webinar. So for now, I will hand it back over to Emily to close us out.
Great. Thank you so much, Zach. I just want to take this moment and thank all of our presenters today for the incredibly interesting and thorough presentations and for the time they've taken to answer a lot of the questions in the Q&A in the box there. If you have additional questions, you may see some of the responses there. Next slide, please, Dakota. I also just want to remind everyone that the next session will take place on September 26th. It's going to just be an hour long. It's a bonus session where we will talk about data visualization and have a great presentation from Momentum Private Healthcare Delivery on their use of data viz and integration with DHIS2 with routine data. So I welcome you to register for that session. That will be the final session of our 5-session series. And I just want to thank you all for your engagement and your interest. And thank you all so much. Have a wonderful day.
Thanks, Emily. Thanks, everybody. Bye.
Thanks, Emily. Bye.